Get a little bit out of your way.
Hey, John, over lunch I need to chat with you for a minute about teaching.
Nope, I don't know where that is, but it's not here. There's, what's it called? Grass.
It's wonderful. I collected
It's your lucky day.
So, you responded back to Chris Turner. So, okay, can you send me the right one? So, I don't think, you're looking at it quickly, and I haven't even read the full thing. I think we just didn't, it needs to go back to the same. Substantive changes.
Give it something.
I see that.
Okay, but it still didn't get caught prior to.
I had a camera here because that is my dog.
We forgot a period or something.
The second link was, there was 2 links. The second link was the early updated.
My old voice.
Because I started with
I think the whole system is screwed.
I can read something 14 years and another person looks at it and I
So here's the problem.
I did bring it back.
This entire process
Throw it at
should go two people in the region, a physician and paramedics, should represent each region of the country. The regions should have protocols that then report up to a collaborative protocol committee.
Oh, yeah.
Call to order the REMAC meeting. Order of business is approval of any additions, solutions, corrections to those minutes which are available on the table there.
Okay, Gus, the first order of business on the agenda, the Sydney EMS has requested provisional approval of ALS status pending receipt of their controlled substances license. What they're asking is that the REMAC attests that they are ready to go to ALS status as soon as their controlled substance license is received by them.
All right, well, we hadn't actually approved the minutes yet, so any...
Oh, I'm sorry. But you had, I'm sorry. My fault.
Any additions, deletions, corrections, minutes, okay, so consider those approved. All right, Sydney EMS pending, there's 2 of these, pending receipt. Both of these are similar, Richfield Springs also.
Right.
Pending receipt.
This is just an attestation on the part of the REMAC physicians that they are ready to go to ALS as soon as their controlled substance license is received from the state.
Okay, these were both formerly ALS agencies that got sidelined by the controlled substances temporarily.
That is correct.
Okay. Any comments, questions about that?
receipt of the controlled substance license is only a portion of it. Having the medications and training your employees would be the other portion. How would you assure that?
Doesn't the license come with that expectation?
I believe it does, yeah.
It's part of the deal.
I think here's what happens. A controlled substance license is not the same as getting ALS privileges. A controlled substance license cannot be granted without the agency having ALS privileges. So what's happening is City is saying they're ready to be ALS, and they have everything in place, but because of the controlled substance law change, they can't be ALS without a controlled substance license. It's a chicken and an egg dilemma.
Yeah.
So what they need is a provisional controlled substance approval so they can get their controlled substance license and be compliant with the law. I'm not recommending, I'm not weighing in. Someone that knows Sydney, you know, I mean, I believe Joe's been working with them, Maggie's been working with them. They're saying that they're ready to go ALS. You know, there's two different issues here.
Hello.
You know?
Hi. Yes.
Sorry.
Okay.
But I mean, I think you're mixing the two issues. They're not one and the same.
Ah, okay, well, I
Okay.
appreciate the call.
You know, one is they're asking for provisional ALS pending a CS license, which is standard practice across the state since the law change. So it's a matter of the REMAC here determining whether or not they can go ALS to allow them to get this.
All right, so that's the, I guess the chicken part of it. Any observations about that? Sydney EMS approving as ALS agency? Imagining a world where controlled substances was supplemental to that. Hearing none, okay. Bridgefield Springs, it's kind of the same question. All right, hearing none. All those in favor, say aye. Aye. And opposed? All right, those pass. Sydney Fire Department requesting their own BLS. Can somebody sort of describe, I should know all the distinctions down there, but in Sydney, what is the landscape of EMS? I mean, you have a Sydney Fire Department requesting first responder, you have Sydney EMS, and you have Sydney Center, which I guess is a whole other municipality.
Different
town. Okay. So what's the relationship between the fire department and EMS in Sydney?
I am from Sydney. I'm a fire chief and also on the Sydney EMS board. The difference is we have the crew that has become paid, 24/7 paid, but we also have 20 people within our Sydney Fire Department that are also first responders. So we would like to be able to have them respond if necessary.
No, okay, so it's in addition to.
It's in addition to the Sydney EMS, correct?
Good idea. Any comments about that arrangement? And so this is a request by the fire department to start a first responder.
Correct.
I have that paperwork, it is complete, and Joe Farrell advises that the REMAC physicians should approve this before this paperwork is passed on to the state, before an agency code can be issued.
All right, and does the paperwork look like it's all in order?
Oh, it is all in order, I have it right here.
All right. Any comments? Anybody opposed? None. All those in favor? Aye. Dr. Fisher, he was in the middle of a sip. He would have said aye. Okay. Davenport first responders. Assumption of, does that mean rising to, for the first time ever?
Actually, they want to drop back from paramedic level to AEMT level of service.
It's still an ALS level of service though, right?
Right.
They're not required to carry controlled substances at that level. That's why a lot are dropping to that level.
Is it still considered ALS
For
though?
billing purposes, yes. They're allowed to. I don't make the rules, I just, it's like passing on.
I'm just trying to.
You're the enforcer.
So this is an ALS agency that doesn't carry control because.
They're basically a first line, Howard can probably explain this better, because he's taught the AEMT curriculum. First line cardiac drugs, the AEMT curriculum.
Oh, okay, this is intermediate.
This is the old intermediate plus the beefed up old intermediate.
That's the
Probably
best way to
put it.
I like it. I like it a lot.
For rural areas, it's a good idea.
confusing though, because we used to use AEMT to mean advanced.
Yeah, and there's enough folks around the room that if I said AEMT4, somebody would go, oh, that's paramedic, and then there's EMT-paramedic, and emergency medical technician paramedic, or just paramedic, or medic, God forbid.
I remembered well, Howard.
Right.
You just get the whole history.
So, it's just what we're doing now.
Intermediate level of service.
It's better than intermediate. It allows
It's like a
providers.
supersized intermediate.
It allows providers to do IVs, intubations, CPAP, all your BLS meds, plus dextrose, thank you. Not 12, well, you can transmit 12 lead, but that's BLS. The other thing that people forget is that nitrous is a BLS modality. So if an AEMT level agency wants to go through the process to obtain nitrous oxide, they can use that for pain management. So I can tell you from teaching it, the pathophys and the assessment are above the current curriculum for CC even at this point in some places.
So this might be the future pathway for type of service.
That was perfect timing. Thank you, Joe.
It's no comment on here.
I like it. I like it a lot. It's popping up more and more across the state over the last couple of years, and I think you're going to find that people are going to use it to supplement paramedic level crews and use it in areas that are rural that can't get either CC or paramedic courses.
So how do we describe it though? I mean, if you have ALS, you have BLS, what's this?
It's ALS. The way I differentiate ALS and BLS are invasive skills. So
it's ALS minus,
it's ALS, period.
well, minus controlled substance requirement, minus critical care drugs,
Right.
minus, right? So
But that's what the intermediate used to be also, so.
So it's ALS.
I believe it was last year that the REMAC weighed in on a subject, and I'm not quite sure where it was, whether or not intermediate was ALS for dispatch purposes.
Yeah, I guess we're still.
And it was last year, we went round and round about that, and you guys said that intermediate was not ALS. They're
For
actually
dispatch.
So I stayed out of that fun discussion. But the bottom line is that AEMT is an ALS level of care, both by New York State and by billing standards. So if you want to differentiate, and my 4 cents, I think you should, between an appropriate level of ALS being dispatched for the appropriate patient via like EMD or silly things like that, I think that certainly makes sense to, just don't blindly call for ALS for chest pain and get an AEMT, because that's not going to do too much more for you. You need a paramedic for that. But if you have a trauma or an abdominal pain and an AEMT is available and a paramedic is a half hour out, then that's perfectly appropriate.
So they defibrillate, right?
Mm-hmm.
And they pace,
No cardiology.
they intubate.
They do. They have first line epi and cardiac arrests.
How do dispatchers handle it now?
That's not a question I can answer, thankfully.
Well, right now what they're doing is it's based on your PSAP. So when they dispatch you to anything ALS, Charlie, Delta, that has to be a medic coming. So when you call in as an AEMT, one, it's confusing, because you think AEMT, you think ALS. As you call as an AEMT, you're BLS. So they send you a medic.
The issue on this is that in 2012, when the state actually rolled out the new level, I think it was 12 or 11 even, might have been December of 11, Andy Johnson put out a memo to each region that said, hey, this is coming, get protocols ready and let your region know that this is coming and be ready to adapt this. We're about 6 years behind on that. So it's just our cart's way in front of the horse as far as letting people know what this is, but it's a good level. It really is. There's plenty of information on the state website on it too. There's even a chart comparison to EMT, AEMT, CC, and paramedic as far as what skills they can do. So, yeah.
Any other discussion? Any PSAP concerns for knowing what to do and how to tone it out, and whether there's liability in calling out a non-ALS service?
There's liability, respectfully, no matter what, because we have PSAPs that aren't using EMD.
Freelance, anyway. All right. Okay, so it's a good discussion. You're requesting to Ms. Davenport moving to AMT level of service. Is it really a level of service? At the individual level, it's a level of service, but at the squad level, is it a level of service as well?
Yes.
Okay. All right. Any appeals to that? Okay, all those in favor? Aye. All right. Dr. Sosnow. All those in favor of Dr. Sosnow as a medical director for Sanity Center? Aye. Summit Fire District Rescue Prevention, the BLS Narcan, do we have to request that?
They do have to request that. They filled out an application, and it is correctly filled out, signed off by their medical director.
Okay. All those in favor? More Narcan. Good idea. All right. All right, so Phil, you got some informational items.
Yeah, just on the rollout of the collaborative protocols, we're still in the training phase throughout the month of March. And the original compact between the regions was that by the end of March, after March 31st, the protocols would be ready to be adopted. And the attestations are being received in the office, and things are going very nicely. We have distributed the links to the Android and the Apple versions of the protocol apps. They're out there now. They were sent out to all the agencies, all of our members and all the agencies, and also the links are on the regional ALS protocols page of our website. So everything is going forward with only just a couple of weeks delay. I was very happy to see there was only a couple of weeks delay in getting the apps available. The app, I haven't looked at I presume the Apple version of the app is just the same as the Android version. It's extremely efficient with all kinds of fancy links on it. So it should be very easy to use in the heat of battle in the ambulance situation.
Okay, that's good. And we forwarded them a memorandum of understanding, is that right? From the REMAC?
Oh, yeah, that was last month. That was the last meeting, I should say.
Right, just confirming that, okay. All right, okay, so that's the protocols. Moving on, the next informational item.
This would be from Mr. Farrell, the BLSFR agencies to be archived tomorrow on St. Patrick's Day, no less.
You're giving me until Monday.
What does that mean, archive?
Basically, you got three agencies who were notified of they were going to be archived. One of which was Wellsbridge, who the third time sent back exactly the same paperwork I sent them back 3 other times. So we'll see what that.
So what are the three? Can you mention?
Have no contact at all since God knows when. So come Monday, they're going to be archived.
So
and that doesn't mean they can't respond. It means they won't be eligible for funding for training.
So they're being sent out to pasture. Is that what archive means?
I'm sorry?
Trying to use an agrarian analogy. So they're being sent out to pasture as a responding recognized entity, I guess.
I'm sorry, Doc. I'm having trouble with my hearing.
It means they're getting boxed up and removed from our service, our computer system as a service.
Okay, boxed up.
Out to pasture, buried, 6 feet under, pick your turn.
They don't know more.
Many more choices.
I'm trying to avoid it being
And that brings up a good point. These agencies, especially if they're like fire-based and want to get their guys up to the EMT level, CFR level, will no longer be eligible for funding.
Right. That's the primary reason for the BLS agency going. It's not that they can't respond. If they want to be able to get reimbursed for training, that's why they need the agency go. And they've all been told that.
Right.
It's not like we're trying to do anything nefarious. They get 6, 7 months worth of notices. After 6 or 7 months.
It was a slow burn.
But they've got notices via email, via snail mail, you name it. Joe is.
They
So
get
for the
4
record,
or
what are
5
the three
notices.
agencies?
The 3 agencies are Wellsbridge in Otsego County, South Minden in Montgomery County, and Burtonsville in Schoharie County.
Burtonsville is being worked on, Joe.
Sorry?
Burtonsville is being worked on.
Yep.
They are?
But I've got nothing from them, so. It's not the end of the world. If they decide later on they want to get the agency code back, they just send the paperwork, we'll give them the code back. It's not a big deal.
So South Burtonville, they didn't sign the DNR and you're resuscitating them actively.
Someone in our office, her son-in-law isn't their chief, so there was a miscommunication there.
Okay. All right, thank you for that information. Further update on compliance with DOH research and inspection requirements.
Everybody in this region, everybody in the AAREMS region is up to date now. So.
Okay. Are we a leader among regions, or are you going to throw out any, attaboys or anything?
I'm sorry, Doc. You
Okay.
talk low, and I can't.
Yeah, it wasn't worth it. Okay, so Ambulance Service of Fulton County requesting REMAC for the Specialty Care Transport Program, and sort of, I guess, kind of coupled with that is the MFI program, or that we do it as 2 separate things, but specialty care, I wasn't really here for that discussion. What's the current, anybody want to speak to this now?
We have several nice folks from the ambulance service of Fulton County here. Mike Tracy, who's a member of the council, and Tom Gully and Roy Sweet, who are not members, but very welcome guests. So anybody who wants to speak up?
I just, as far as we go, we answered all the questions that the doctors had emailed us. Dr. Funk had asked some questions, and we responded to her and forwarded everything to Phil. And we had talked to Dr. Fisher and Dr. Ivanowski about their questions, and I think everything was answered as far as that goes.
All the physicians we spoke with are in agreement that they should be allowed to go forward with this program.
Okay. All right.
Mike, can we go to this next topic? Because I think that the acuity of the patients, there's no split level. So I think that intubated patients certainly need MFI medics. That's part of a discussion now. We're going to be the next topic. So where does that, I guess, I think that needs to be addressed more than anything.
Well, for right now, the two topics are we'd like addressed separately, the MFI and the SCT. Yes, they are combined in and of themselves. However, right now, patients being transported by our agency with a nurse and a respiratory tech currently are not at an MFI level. They're being transported in propofol. So I agree with you when we had discussion before about the need down the line for MFI, and we said that that's a topic that we were looking at later on, but we wanted to get everything in a row. We didn't want to come here and say, hey, we want the sun, moon, and the stars. After our lengthy discussions with Dr. Glenn, quite a bit about the SCT program and getting that up and running, the agreement was that we wanted to get that core group trained and operational. And then our last meeting with him was that he approved the beginning of requesting the MFI and get that training done. So tentatively we have training scheduled in April. We have quite a few of our medics who are MFI credentialed within REMO. Not that that's necessarily, it's Dr. Glenn's purview and his alone on what he would like to accept or not accept. He has made it clear that for right now, MFI was only going to be open up to, he felt confident that the medics that attained the extra credentialing for the SCT program were at the level where they've done the amount of hours that they can move into the MFI program. And we have tentative training scheduled for April. We have 2 medics from LifeNet coming down to do some training with us on that. And then, so we have those courses scheduled. As far as being one in of itself, the MFI and the SCT. The SCT right now, even without the MFI, would be an increase in patient care because we have our own medics trained to be able to handle that. And we're working with the emergency department with over at Latour and the respiratory therapy department on a continuing basis to keep that training up and keep a working relationship. So the MFI is an additional thing. We do have training set up, and we would like to approach the REMAC about the certification for that as well.
So again, my concern is you're taking a vented patient out of an ER or a unit, and for whatever reason, that tube ends up going away. How do you manage that patient with non-MFI medications or credentialing in difficult airway and MFI?
Well, right now we're managing it the same as we would if we, out in the field, we have patients who are intubated who are, we have fentanyl, we have Versed, granted not, the best way to keep them intubated. We have etomidate. So we do have tools available to keep them sedated. We would not be proceeding with an hour-long transport if that tube came to dislodge. It would be a diversion to a closer hospital with contact with medical control if it's an unsecured airway.
You said you're going to be traveling with a nurse with those patients?
No. Currently, right now, without being SCT qualified, what we do is we have any patient that's intubated, we're taking a respiratory therapist along with us and a nurse for the propofol drip. So,
do you have your own vent, or is it?
We do have our own vent that people have been trained by respiratory therapy at Nathan Latour.
Oh, what sort of a vent is it?
It's an HP 300.
So let's take it as two separate questions, because I think they can be linked, they can also be unlinked. So the first question is approval for SCT program for Fulton County.
Gus, just to continue on with this discussion, I understand, and listen, I'm in favor of you getting this program. I just think that it needs to be done correctly. You're involving now, you say if that tube goes away or something happens to that patient, you're going to divert to another hospital. You have EMTALA rules that you have to follow. Joe was involved in an investigation with us at a hospital over a simple thing where a patient extubated themselves, got re-intubated. DOH came in and was investigating the hospital. The hospitals have to take some sort of responsibility too, because under EMTALA, they have to make sure that the staff that are going on this ambulance is an extension, a true extension of that hospital. And the answer of, well, we're going to divert to a closer hospital, I don't think is the answer. I think the answer is you need to come and get an MFI program in place and get these SCTs medics credentialed in difficult airway in MFI.
Most of our medics for the SCT program have SCT elsewhere. They've already had MFI elsewhere. They already have MFI credentials within REMO. However, Dr. Glenn has also requested that they take our MFI class here that we're having in-house by the medics with himself being present to do the lab training.
Okay,
so
let's let Howard jump in. I can see he's got something.
Just a couple thoughts. I think that if you flip these in the order of the way that they're being brought up today, you might get a little bit better support. And, you know, I don't know if people are aware of it. When I say people, I usually mean medical directors. But RSI, rapid sequence intubation, we're calling it MFI, but that's what it is. It's RSI. Especially with the new protocols being rolled out, it finally truly is RSI, where we're sedating and paralyzing for induction instead of just sedating. We're actually doing it right. That's a entry-level paramedic skill. That is in the education standards for every paramedic coming out of school now. Now granted, it's a big boy, big girl procedure, but it is still base level education. So I think respectfully to go to SCT, which is clearly above paramedic, without making sure that your staff has trained to an RSI level, which it sounds like a lot of them or most of them are already, would probably be irresponsible if you ended up having critical patients that needed intervention and you were incapable of providing it. And then, you know, other questions just come along with, like, what else? It sounds like you guys have a good approach towards this. What else do you have? Like, what are you using for video laryngoscopy?
We're using King Visions and Anesthesia Associates video stylettes.
Okay, so you're all, like it sounds like you're working towards the right goals. I think that I flip your order, though, and I get your RSI set up and credentialed first, and then move forward with SCT. I've never, ever seen, and there's 2 national SCT curriculums, I've never seen one that didn't incorporate RSI as a part of base level understanding coming into it. So I don't see how you can talk about vented patients and heavy duty meds without having that RSI base paramedic education to build off of. But
All right, so let's reverse the order. MFI. So that program, is that ready to, you're just looking for approval? Also,
that is correct.
Dr. Glenn is on board, you have a curriculum and some folks
Yes,
already.
we have the curriculum. He's understood that we provided him with the people who are credentialed in REMO. Him and I have discussed it quite a bit, whether or not, you know, it's something we don't take lightly, that the MFI, if it's done, you know, more than a couple times a year, it's something we really need to look into, especially which provider is doing it. The people who are going online with the MFI are people who have credentials elsewhere within REMO. For right now,
what is your plan to keep them credentialed? Because, and this is just a sore subject with me, because it took us 3 years to get MFI. And we had to come here with, I don't know how many docs behind us, and a plan of how we were going to maintain our credentialing with true MFI courses every 6 months, we require our MFI medics to be in a class every 6 months. So
And that's
where
what-
is the plan?
That's what our plan is as well.
Coming
It's-
here and talking.
We are tying the MFI credentialing as well as the SCT skills update to the 6-month AAREMS updates. So all the people who are MFI and SCT will be required every 6 months to update. We've basically taken, we're not trying to reinvent the wheel here. We've taken another agencies at their, we've asked, we've taken other agencies within REMO that they've had long-standing MFI program. We've taken their skills update procedures and whatnot. We've used a lot of the skills forms from LifeNet. So these are tried and true forms. These are tried and true updates to keep them updated every 6 months. And again, Dr. Glenn, it's something that, again, he doesn't take lightly either. So that way, every 6 months, they're credentialed individually by Dr. Glenn.
The other part, thanks for reminding me, Tom, the other part of the MFI approval was that the medical director would submit each 6 months a report on activity within that level.
Yeah, I think if this region is the same as the rest, it comes with a submitted plan.
Right.
So we need to refresh all of this, I think, as we go forward, because the re-update in the process, of education is great, but what we want to see is a letter from the medical director saying everything's, I've reviewed the cases and everything is fine and straight.
Correct.
Gus, I think all that needs to happen is that a formal plan just needs to be submitted that includes training and ed and the curriculum to the region for approval on it, right?
Right. Phil, do you have that?
I do not, no, I don't have anything for their MFI yet, RSI. Good.
Dr. Glenn was expected to be back. Unfortunately, he's skiing in Colorado right now.
Unfortunately,
But he could have stayed here and skied.
Well, yes, he could have stayed here and skied. So he's decided not to come back to the several feet of snow right now. I mean, we really can't blame him. And until I saw the agenda, I wasn't entirely sure whether it was actually on the agenda for a vote to the REMAC. We do have something with Dr. Glenn where he has approved everything. So we do have a plan in place that's been signed off on him. Unfortunately, I said, I didn't see the agenda with the MFI on there. I knew the SCT program was. My belief was that the MFI was just for discussion. And so I apologize, I don't have the signed plan currently.
Okay, so,
Can I ask one question?
sure.
Do you have a CIC that is signed off or is willing to teach us so that you know that everything that's being taught is in line with New York State standards?
Yes.
For which level are you talking about, Mary?
Huh?
For which part?
For either of them.
Okay.
I mean, technically, you're supposed to have a CIC oversee or work with and do the training. I mean, we've had docs, and I'll pick on Albany Med, for example. Albany Med's training, our pro has to be in attendance at all those. That's the CIC, because occasionally the residents will speak out of turn and not realize what's appropriate for pre-hospital and what isn't.
So what you're saying, both RSI instruction and
MFI,
RSI should have a paramedic CIC tied to it.
and as well. for specialty care
SCT technically is
transport.
above and beyond the
it does have
paramedic
New York
curriculum.
State's scope of practice technically, but I mean, ideally,
And the same thing for specialty care transport.
SCT is technically outside the scope of practice in New York State. It's above and beyond.
So, all right, let me throw this out to Fulton. Can we defer table these topics and then come back? I guess the list would be, treat them as separate things. We'll front end the MFI first. CIC instructed.
We do have CICs overseeing the MFI.
Well, I think what the group is saying, they want to see the plan.
Yes. Well, right now, we would like the MFI was a topic of discussion, and we're more than willing to submit the plan as soon as Dr. Glenn comes back from his skiing vacation to Colorado. What we'd like right now is a approval to begin the SCT program with the expectation that the plan for MFI is submitted to the region.
I think what the group, what I'm hearing from the group, is that the chicken in this case, I guess it depends on how you look at it, is the MFI program. get that
Well,
up.
MFI and intubated patients present less than 3% of all SCT runs. So that by far and large, the majority of the SCT runs are going to be, your heparin drips, your, Vanco drips. So we see it as, yes, there are aspects of SCT that are incorporated in MFI and vice versa, but by far and large, SCT is anything above what the scope of practice is for paramedics, meaning the simple act of transporting an event, or not event, as a pump, is technically considered an SCT. Even if you just stop at that, it's all an incorporated aspect.
Respectfully, no, it's not. It's outside of Article 30, but SCT is a specially formulated program that really brings your service to a higher level of transport. You can work with your medical director to provide in-house training outside of Article 30 so that you guys could take heparin regularly. There's a bunch of commercial services represented in the room, and I know they'll back me up on this, but you can train your paramedic staff to do, if that's primarily what you're getting, you can do that in the meantime. And honestly, I think you've got good support in the room if you just go through. I'd even suggest that you keep going with your RSI courses as long as you do it and then come back with a plan and keep going with your training. It sounds like you get it. But yeah, if you're looking at just isolated meds, you can work with your medical director to train your staff to take certain meds on pumps. You don't need SCT to do that if that's what you're looking for. But we can catch up offline if you want. I can help you out with it.
How many agencies in AAREMS are SCT or MFI?
I think CMT is MFI.
CMT is SCT, but we've never done MFI. So
Alright, so
hearing
Adirondack
this
is the
discussion,
only
we're gonna
MFI
have to bring ourselves up to.
And you guys aren't full SCT either.
So there's going to be the third SCT agency if they're successful, and the second MFI.
I think GAVAC's the only true SCT in the region.
So,
You only MFI.
respectfully, are we able to get a vote on this has been several months in the making, and we've been submitting information and doing as much as we possibly can to answer all the questions submitted to us. We are looking for at least a vote to begin the basic SCT program, with the understanding that we will submit to the region, or at least a tentative start to our SCT program, pending approval from our MFI.
My question is, and I don't want to throw you guys up under the bus, but if they're SCT and not MFI, why aren't you asking them the same questions you're grilling us on?
That just came to me.
Oh.
I just found that out myself.
We've tried to answer as much questions and go through the process. We're not trying to ask for any sort of special treatment, and we're more than happy to do any sort of requirements that the REMAC is requesting. We just want to make sure that.
I guess I'm with Howard. What prevents you from doing the transports of heparin or these other drugs currently? They're within the protocol for under the interfacility transport protocol.
But
So
there,
you could already
there is, as of the first, there is no more interfacility transport protocol. That's all got to be decided here.
What's in our protocols?
Not the new ones.
Not the
It
new
is.
ones.
I'm looking right at it. It is. It's in the protocols.
Are you looking at the new version or the old
The
version?
new version.
The new version doesn't have.
Interfacility transport.
When CMT has or an SCT run, do you take intubated patients?
We do.
You do take them?
But you have to understand, I think our SCT program was submitted 15 or 20 years ago, and it clearly needs, hearing this discussion, it clearly needs to be upgraded.
Your SCT program was approved before MFI was a paramedic protocol.
So now there's some growth here that has to happen at CMT as well.
So SCT is regional. SCT falls under regional, but interfacility covers paramedics and critical care techs. For patients between facilities with standard IV infusions flowing, including antibiotics, then it says, it just goes through all vasoactive medication drips and fluids containing potassium must be on an infusion pump. So I guess what's preventing that from happening currently? If your staff has been trained on the pumps, they could do that. I guess my concern is, it is common, in whether it's ambulatory, we go into ambulatory occasionally to take these intubated patients. These patients are patients, they're coming out with 5, 6, 7 medication drips in different vent settings, and you truly have to manage that patient. Things change in the back of the ambulance. It happens every single transport. It's not, unless you're doing just a vent run to, to Ghent for rehab, to wean them off a vent. These are sick patients, and there's different things that have to be changed, whether it's pump settings, whether it's vent settings, to truly manage that patient. And we have been in the position where, a patient has moved, and the tube has become dislodged, or you had a vent problem. That's my concern. And while that's only a 3%, according to what statistics you have, we find that to be, while it's a lower percentage, we still do a significant amount of vent runs, several a week. So I think that to put the agencies and the hospitals at risk by not having, I guess, the horse before the cart.
But that's essentially that each sending hospital has to be comfortable with whatever crew is taking them. Even if you are an SCT and the sending physician feels that you're not at the level that of care, the hospital then can defer to another unit, the helicopter crew or whatever.
Or choose
I've
to
never
send
known
staff.
that to happen.
Or choose to send staff.
I've never known that to happen. In a majority of cases, the hospitals, the doctors, and the nurses don't realize that that patient is still their patient until they reach that destination. And that is a problem. And when you get to an ER, and we've done this, we've gone to the ER or to the unit and said, this patient isn't stable enough for transport, we're not doing it. But they don't want to hear that. They want to hear, get the patient out of here as soon as possible. And that is a problem. And to just allow that to happen and say, yep, okay, there's no doctor that's going to know. I can tell you that the hospital doesn't know who's coming in on a helicopter. They're just assuming that the people coming in are trained to the standards that LifeNet provides. But they aren't comfortable. They don't know those people. I think in that aspect, you have a significant advantage in having a relationship with the hospital. Again, I don't know behind the scenes. I know when we put our program together, we worked with the hospital, we went to them, we educated them on what we could do, what we wouldn't do, what our policies were. Intubated patients on a vent are a 3-person run. We have 2 medics in the back for those patients because they're complicated patients.
We have no problem with playing by the rules, and we just want to make sure that the rules are being treated fairly. And when we began this, we were never informed prior to this that we want you to have MFI credentialing before the SCT.
2 months ago I sat, or the last REMAC meeting, or the first REMAC meeting that this came up, that was the #1 thing that I brought up, is where is the MFI and the SCT training?
And again, not to throw 3 guys under the bus, but there are other agencies operating with SCT without MFI capabilities. So,
but here's my question to you, and I think this is what the hang-up is, and I think this is where Tom is coming from. SCT is not every interfacility transfer. There's nothing saying that you cannot do interfacility transfers. How many SCT calls, in your mind, have you turned down because you're not credentialed by this REMAC?
Quite a few. When we began our investigation, we're turning down roughly about 15 a month that we're turning down. So it's quite a bit, especially with the new protocols coming out.
You're turning them down as in you're not doing them, period, or you have to bring a nurse?
We're turning them down either not doing them, period.
So who's doing them?
Or
Because I know
they
we're
are-
not doing 15 a month out of
Or
Latour.
they are some are going to Mohawk, some are going to you, some are going to LifeNet. But I said, we're all for doing our due diligence. We have the MFI program up and line, and again, I apologize for not having that. I did not know that was on the docket necessarily for today for a vote. But again, my concern here is the rules being applied equally and a potential conflict in interest.
All right, let me jump in here and throw something out that maybe will find some traction. So is the group, it sounds like the group is of the evolved opinion that SCT now, contemporary, should include MFI.
If you're going to have preventive patients, correct.
Must.
It's a must.
Well, we can't say must.
You can. RSI is a part of the national standard curriculum that's adopted by the state for paramedics.
I have CMT in the back of my mind and saying, what if we said, okay, we can agree that that's the new standard, and everybody's got to meet that standard, but they're going to need some time to come back with their MFI plan, QI plan, re-education plan, CIC plan. Because we don't have it now from Fulton and CMT. We need to develop it. So, what if we said provisional approval for SCT and 2 months to come back with an MFI plan?
We would have no objection to that.
With no vent runs? In which they can't take vented patients?
The vented patients would be at the discretion of the hospital emergency department. They are the sending facility.
So they'd send a nurse and a respirator.
If they feel that is needed, if they feel that it is capable within the SCT medics, that's a sending facilities. It's the physician's
It's your medical.
decision.
It's your medical director.
And our medical director and the physician that's sending is the one that.
I think that you're putting your agency, the hospital, and your medical director at significant risk. I'll leave it at that.
Well, we know how you feel about this.
With all due respect, I would like to bring up the potential conflict of interest of the agency.
We're going to play this card.
How many?
He just said that
we
support it. I went through 4 months ago, said put the MFI program first. Put it together. You've not done that. We support the program. We know. Yesterday we turned one down out of Latour. We can't do them all.
So we have no objection to the provisional, and we will submit to the REMAC the required MFI credentialing.
Dr. Fisher, you had a comment?
I was curious, how many patients that GAVAC transported via this extubated themselves that needed to be, the ambulance needed to stop and needed to re-intubate the patient?
We've only had one.
And when was that?
I don't know.
And we actually had one last week that we had to intubate en route. We had to RSI en route because the patient, respiratory status failed.
So then limiting intubated patients would be.
I have no vested interest in either side of this whatsoever.
Right.
I think to put SCT before RSI is irresponsible for patient care. And I fully support ambulance service Fulton County in doing this because we don't have the resource out here.
I do too. I support it. I think that the horse needs to be before the cart.
The trouble is what happens if you have a critical patient who then needs to be intubated and is either a tough, it sounds like they've got everything set up, just the training and the plan.
We would be even willing to submit to a provisional start for the program with the understanding that as soon as Dr. Glenn comes back on Monday, we could submit to Phil on Tuesday the plan and have it sent out by email to the physicians as well. But we've been months and months in planning with a considerable expense as well on top of that. We're looking for at least a provisional start. We will submit to the REMAC. You'll have it on Tuesday by the end of the day, our MFI credentialing as well as our CIC plan.
Yeah, just so we're in sync with what we've we've said in the past, make sure, Phil, that the MFI checklist is exactly the same that GAVAC was subjected to in terms of.
But listen, it's already not. If you approve this provisionally, it's already not. You talk about violation or playing favoritism or playing by the rules. We had to come forward with all this stuff. CMT, I'm sure 15 years ago, came forward with all of their stuff. And that's how we got approved. And now we're just going to waive those rules and say, okay, well, you could submit them whenever.
That's not what I'm hearing. I'm hearing SCT is not approved until RSI is approved.
That's not what's being asked for.
Well, what is provisional?
That's what I asked. What's provisional? Either you're starting it or you don't.
We're asking for the
Provisional.
approval to begin the program pending Tuesday. By the end of the day, you will have the MFI credentialing. Again, like I said, I apologize that it was not on the docket. We were not told prior to today that it was a condition for the SCT program. So by the end of the day on Tuesday, we will submit to Phil the entire MFI credentialing, the entire plan that is already put into place. Like I said, we borrowed it from other agencies that have long-standing programs. So we will submit that by the end of the day on Tuesday to submit to the REMAC positions that we do have MFI credentialing.
How long is it going to take to get your staff trained in MFI?
Our staff, most of it has already had been trained in MFI, the ones that we're looking to go online.
But your doctor wants everyone
But our physician just wants to do a one-on-one. It's his license on the line, so he just wants to assure that he's watching somebody do the lab skills for MFI. So he's coming back, like I said, he's coming back on Sunday. Unless somebody's dead or dying, we don't dare call him on Monday. On Tuesday, we have a meeting with him anyway because we have to discuss some things with Dr. Daly. So we can submit to the REMAC.
You're submitting the plan on Tuesday. How long till he signs off on the people in their credential? That was the question.
Dr. Glenn, that's Dr. Glenn's probably, it's a lab time, so it's scheduled lab time. If it's important for it to start the program, Dr. Glenn wants the program started and he wants it. He's pretty upset that it's been going so long.
2 or 3 weeks.
Yeah.
Yeah, that's all we want.
Within 2 weeks.
Within 2 weeks.
Is the class in April?
We do have a class in April, but it's mostly for people who have not attained MFI, who are interning under credentialed providers.
But I thought you said you wanted everybody to go through that again, even the ones who are MFI.
Yes, and everyone's going to go through the skills, but prior to going online, they want to sit down with a lab with them, doing scenarios.
Everybody's going to have to because the whole RSI
Yeah.
protocol has changed anyhow.
Okay, but you're
So
saying 2 or
every
3
provider
weeks
has
that
to.
sent from tomorrow or Tuesday when you submit it?
Yes,
2 or 3 weeks?
our current people who are provided, who have MFI credentials down in Remo, within 2 weeks will be re-credentialed by Dr. Glenn with the new standards in place.
But without going through the course that he wanted everybody to take anyway.
Everyone's going to have to go through that course as well, as a refresher.
You're contradicting yourself with what you said earlier and what you're saying now. And that's where I think people are getting confused.
Well, on April 15th, it's a new MFI course, so it's a new course being taught. People who have never had MFI, it's geared towards them. Dr. Glenn wants the people who are already MFI to go to the class, mostly for assistance with the other people, but also as far as CME as well. He wants them to go.
And he's willing to sign off on them before?
And he's willing to sign off on them before. I mean, he's the physician, he's a doctor, so we jump and do what he
Right, it
wants.
just didn't sound like that's what you meant earlier.
I apologize if it was not clear.
All right, somebody want to make a motion? Get us out of the Sargasso Sea of indecision.
two that can make motions?
And the doc in the corner.
Yeah, we can't go.
So, your original motion was to give them a provisional approval?
I threw that out there in the hopes of extricating us.
I mean, as part of that provisional approval, I mean, is there not the ability to put a restriction on that intubated patients will not be transported pending full RSI certification?
Yeah, and,
I mean,
you know, Dr. Fisher brings up a good point, and you know, Mickey brought up that last week we had to intubate a patient. I mean, these are sick patients, so it could be any SAT run, not necessarily just them.
Oh, I see what you're saying.
Right. That can happen on any transport, though. I mean, you can't predict the future.
I get you. Okay.
I guess the only other question is, so there's a bunch of paramedics that have experience that do this that will go through the program, but they're already approved. Then there's a small group that, what it sounds like, didn't go through this. So if we make a motion to approve this, then the ones that aren't previously approved for RSI, to exclude them until they go through the course, and the other ones can be approved. So if you can put that into a motion, we can do a provisional approval like that for the select group of paramedics, and that can go into effect when they have their plan in, and we approve that. We can do that online, we don't need to wait until the next meeting. And then after the other ones complete the course, then they can be added on so they'd be in full compliance, which will limit the transports when, you know, when the other people aren't available, but at least it's a step forward.
Can I suggest that?
Does that make sense? Go ahead.
Yeah, that's fine. We can, provisional approval to begin the MFI, to begin the SCT program, only utilizing those medics currently that are credentialed within the REMO region for MFI, that we will submit to the REMAC by Tuesday, close of business, our MFI plan, along with our list of CICs. Is that summing up? I'm just trying to make sure I understand everything that you were...
Yeah. Howard, what's the problem?
Well, I mean, that's fine, but if you're following how everybody else in this region in Remo has applied, the REMAC gets an application to go RSI. That's usually forwarded by the ALS coordinator and the physician of the agency. If you don't have that, are you proposing that that would be voted on electronically by the REMAC, and then permission would be granted to go forward with RSI and then SCT?
Yeah, but also included in that paperwork is the training outline and stuff.
Right, exactly, yeah.
And I mean, no offense against the docs, other regions have both the docs and educators look at the training for all of its components.
This is new for me here. Usually, for what I've seen GAVAC's proposal, and I've seen at REMO, tons of agencies come forward where the ALS coordinator and the medical director come forward together at a meeting to the REMAC and say, hey, look, we're looking to do this. This is why we're looking to do this. Usually there's a presentation of some sort with this is the training and ed, these are the statistics, and this is where we're going forward. That packet gets then approved by the region, and then the region says go forth and do RSI. SCT is a little bit more of a notification, but what needs to happen for SCT is that same similar process, and then this is our training curriculum, and then that gets approved because SCT is between the medical director and the agency, not really within Article 30. So I don't know how you guys are going to choose to handle it here, but it sounds like you're on the precipice of making a big decision and establishing precedents.
I don't feel like I'm on a precipice. I'm waiting for the group to come up with a motion. We can table it.
I just think without the plan, when we had to come here, Rich Beebe came here and laid out our education, laid out our training, laid out our how did they,
I mean, it took you guys almost a year's worth of meetings to get approved.
Here's the other thing too, is because I hate to see them leave the table and go, we're trying to do this and can't do it. There's no reason why you guys can't push forward with your education if you're following national standard for SET, and I don't know which agency you're using, but which agency out of Reno are you?
The Bureau of Critical Care Technicians, the National Association of Critical Care.
No, for RSI.
What's that?
Remo agency?
Remo.
Which one?
Yeah, which one?
Moreau.
Moreau, okay. So, you know, if they're using one that was credentialed, and if you're taking the whole thing and just using it the same way, at least you know that it's passed by REMAC. I'd say go forth with your education, and then you're still going to have to come back for application, but at least it doesn't slow you down if you're doing everything that's in the national standard curriculum with a CIC and a REMO-approved RSI setup. I don't remember, Mary, you might. Moreau was approved, right?
Moreau was approved, but I know there were certain caveats with it. They did it with multiple agencies involved.
Right.
They do a signal 41, just you have to have two paramedics.
Right, they have a whole Saratoga, that's
Right.
different though, they have a whole Saratoga County system
Oh.
for the northern end, or that piece of Saratoga County. But what I'm saying is, you're saying you're using LifeNet stuff for this, you're using Moreau stuff for this, you're using Remo's, you're using NAEMT. I think the concern here is you're picking and choosing from the Chinese buffet to have the whole package. I think that's where Howard and some of the other guys are concerned.
No,
No one's arguing with you guys trying to do the best possible for both the patients and the providers. But they just want to be sure all the bases are covered. I mean, taking 4 months to get approved for this.
As far as the forms go, we're not picking and choosing.
No one's talking about the forms, everyone's talking about the training and being ready to go.
It sounds like you have all the pieces almost together. It seems like it's order. I'm just trying to. I don't have a vote. I don't even sit here. I'm
I
just
think
trying
everyone
to
would just like to see the
you
whole
get
cake
something out of
rolled
this.
together.
I don't want to see you walk away from the table today and go, we got nothing done here. We're just trying to do something good for our patients. And I know you're feeling that way. You're frustrated.
Well, our concern is that we haven't been notified that we must come with a MFI credentialing in order to get this done. And the fact that, again, that there's other agencies that are currently running SUT without MFI program.
Right, but that in and of itself doesn't matter because that came up today, so that wasn't
correct.
part of the
Was
discussion.
there ever a checklist that was given to GAVAC when they did this? I understand CMTs is older than
Dirt.
you know.
Yeah.
And if there was, has that checklist been given to Fulton County Ambulance?
Of the requirements?
Yeah.
We submitted?
It sounds like the best thing to do to make it clean and clear, and I know you want to get this off the ground, but we need to table it today, get all the ducks in a row, and bring it back up when all the ducks are in a row.
By giving them a checklist of what's required.
Well, it's not something we hit often. When did you guys become, I mean, it was before I got back in 2009 that you guys went through it, and I'd have to go back to the archives to when we went through it. It's not something that happens a lot. So having a checklist, and we're identifying these problems because it's been close to a decade since any agency has asked for this.
The other thing is, Beth, if I could bring it up, if anyone's looked at the protocols, basically any specialty care inter-facility transport now falls back on the region. It says so right in there that there needs to be regional guidance for this, okay? This previously wasn't the case. There was more in the protocols. Dr. Daly took it out of the protocols and threw it back at each individual region. So while this may seem like they're being exceptionally harsh to you, you're also playing under a different set of rules because the rules have changed.
Now, is this something that the region should come up with a plan, a regional plan as far as curriculum, training requirements, a set standard for anyone who wants to go this route?
It's going to have to be based
I
on the
think it's got to be a
protocols.
policy. It may not necessarily be putting together what you have to train in. They're training their people to the national standard, which is fine. We can create a policy that says that you need to pick one of the two national standards and train them to, but you need to submit that curriculum.
Not that everything that Remo does is perfect, but what they had decided to do was their academic committee, which reports to their REMAC on training and ed issues and protocol. the REMAC basically said that if you're gonna come forth with an SCT or an RSI plan, it has to be brought to the academic committee, approved by them, and then forwarded by the REMAC, approved by the REMAC to say, yes, this is an acceptable training ed plan, go forth and do. When we did that, we had flat out said that it has to mirror one of the two nationally accepted SCT curriculums.
And I think, too, there needs to be an ongoing thing to make sure that CMT doesn't get in the position they're in right now. They were approved so many years ago, but it hasn't been brought up to the present. And no fault of anybody's, but how do we stop that from happening again? And instead of coming here and you know, making 15 trips and saying, oh yeah, we need this, and oh, whoops, we forgot to tell you we need this. Here's a checklist, here's what's required, here it is, and then you don't have to play around with it for a year.
So it might be worth, the best thing to do is to table it, but in the meantime have, like, and I hate to volunteer people, Tom, Beth, and you guys from Fulton County, and maybe Howard, as an educator, come together. Deb is like a visiting person from Remo. I can't throw her under the bus here.
I did.
But actually, Deb,
You're forming an ad hoc committee.
but Deb, not necessarily as from Remo, but as a critical care nurse, look at what needs to be developed for all these to come up with a plan, so you guys aren't reinventing the wheel every time. So I think that would be the best thing to do.
Honestly, Joyce isn't here, we can push her under the bus. This is probably perfect to go back to the regional training and ed committee.
But I wouldn't make these guys wait. Let them get started on it now.
Oh yeah.
With working out a plan for, hey, this is what everyone needs, so it's fair.
Most of it's out there already, and it's just done. It's changed the agency name and go forward.
So one of the two educational programs are out there. What are they? Just for the record.
The Cincinnati.
Yeah.
Cincinnati.
And what's the other one? Cincinnati's the one that I use. Mickey, what do you guys?
Baltimore?
The Baltimore one?
Yeah, UMBC.
UMBC.
But it would be worth having these guys get together in the meantime, come up with a checklist of, we'd like to see these components, bring them back to the REMAC. You guys will already know what's included in it, so you could bring forth your plans. These guys vote on, hey, here's the checklist. Everything should be ready to go.
And just make sure there's a QI arm to the plan.
Well, Howard threw Joyce in.
You guys utilize or mirror the UMBC, didn't you?
Yes.
Yeah.
I can't make a motion.
Yeah, I know.
That would be my idea.
I think Beth suggested a motion. Beth's going to make a motion.
For, I'm sorry, to table it and get all the ducks in a row and come back to the next meeting?
I would form a working committee or tag, whatever you want to call your group.
All right, so the motion to table these two motions, do some homework at the regional level, encourage training at the local level, either Baltimore or Cincinnati, MFI training modules, and then come back as soon as, I guess as soon as we can. It doesn't necessarily have to wait for the reconvening of this meeting. So is by next meeting quick enough to get out the training ed guidance? All right.
I think that just submitting the plans, you know, your nationally approved program, MFI, if you're using Morose, which is already approved, put it in a package so that everybody can see it.
Can we submit to Phil next week for our paperwork for a electronic vote by email?
On what?
On the beginning of the SCT program for submitting the MFI curriculum?
It sounds like
If it's packaged, if you package RSI in your SCT,
Are the
and it's approved.
physicians open to receiving the stuff by email if it's?
Well, I mean, one of the suggestions in that embedded motion to table was to develop the framework so that, I mean, it sort of got highlighted by the question about the checklist. So, you know, you went bowling and then told you that the alley was not where you thought it was over here. And you kind of didn't get any pins. So now we're trying to all reassemble the pins and say, what is the checklist? What does the region want to see from any agency coming forward with MFI application? It sounds like MFI is a prerequisite for SCT. That's another decision that will affect CMT as soon as we make this motion. So the framework hasn't been formulated by the region yet. So once again, you'd be bowling away. The physicians be asking to vote on your bowling performance without any grid to know how many pins the region might come up with that you then didn't hit. So rather than go into this sort of cycle of like, sorry, you missed the pins that the region just devised, we need to back up and get the policy and the checklist sort of formulated, it sounds like. Which shouldn't take long. It could happen, could happen probably between now and March. Go ahead.
So we just let me be clear, because I guess that's our sticking point, that nothing is, we have no problem adhering to rules as long as we know that what the rules are and, that they're applying thereon. So.
Well, the first thing is there's a motion to table both these.
Call the motion. Call the motion.
All right, so you should call. All those in favor of tabling this for later resumption? All those in favor?
Well, just do docs.
Aye. All right, so it's been tabled. That means that everything is possible, but not now. Okay. So, moving on to the agenda, REMO medical control system. Dr. Fisher, you're listed.
Oh, just the REMO does all their calls at 8, and it's really not that expensive. I don't know what the exact expense. I talked to Phil about it, but I think you probably should move towards this because it's cheap, it's very good, and it really protects the medics for if the physician gives an order to them, this documents it, so it's like definite. There's no he said, she said stuff.
And it's also one central number as well.
Yeah, so
one central number, yes.
I remember Dr. Daly extending this sort of discounted option for us as a region to lower their expense by adding our region. And it's a cellular-based system, right? So it's a cell phone technology that gets recorded. And is it 100? Does it have to be 100% across the region? Otherwise, you'd have holes in your data.
You're describing the system. Can you describe the system so everyone understands?
Sure. You pick up the phone, you dial one number, you basically hit the encoder frequency number for that designated hospital.
You pick up your cell phone, which doesn't work in any parts of our
right. You tape a note to it.
You have to like.
It can be any phone. It can be a cell phone. It can be online. Any phone.
Any phone.
All right.
Call the number. It says, "Thanks for calling medical control. What hospital are you going to?" You punch in the 3-digit extension that corresponds with your BLS encoder number for the hospital. So for St. Peter's, it would be 015, and it essentially forwards that phone call to St. Peter's.
So a dedicated line there,
And
presumably.
sometimes not even, but a set number. And then it records your conversation all the way through.
It is built into the app that Phil puts
So it's like a
out.
listening on, so it's a triangulated thing.
It is
It's being
built in there.
recorded.
Give me some credit, Phil. Here.
It's
So
it's
Phil, I
really
remember-
nice to have.
I remember we actually looked at the price tag for this for the region in the past. What
It
is the
was,
new price tag?
it was about $1 a call, as I remember.
But like agencies like GAVAC will end up paying much more than an agency like, I don't know, Sydney.
Because they didn't overcall.
So that was a region by region decision. Remo decided to turn around and pass the cost on to the agencies. I think they're charging something like $1.50.
I thought it was $1.10.
Okay, either way, $1 and something per call. But if you guys are lower volume and have different ways to offset that cost, that's up to you guys as a business model. I will tell you that if I had to pay the $1 out of my own pocket, I'd probably pay it because the number of times that I can turn around and go, no, this is what they said.
And what about review on the back end? If the St. Peter's ED physician wants to review that call from 2 months ago.
There's availability at Remo to access that call, and it can be sent to the physician, could be sent to the QA committee as a waived file for review.
For how long?
And historically,
it has benefited the medic more than it has the docs.
Which is gonna create an issue on the hospital side. Hospital legal will wanna be involved. With any possible discussion on this, hospital legal will definitely wanna be involved because the physicians they're contracted to provide care are now being recorded in the orders that they're given, so I guarantee you.
So it's more accurate reflection
I don't
of what was
disagree with
done.
you, but I just know how far, we've talked about this and reporting, you know, when Gavitt calls us now or any other agency, and there's been a lot of discussion about that, so.
Isn't it in regulation that it should be a recorded line?
We don't have
I believe-
regulation, that hospital
Mary?
regulation doesn't require us to record it.
Isn't regulation say that medical control should be a recorded line?
No.
No? Okay.
What regs are you reading?
I'm just pulling something out of the back of my brain and asking for clarification.
Well, there's no
That's all.
requirement that it be a physician even. I mean, if a med order is given, that's true, but a lot of calls are not received.
It protects both ends, both the physician and the
Now,
EMS provider.
can some agencies adopt this? It doesn't have to be globally across the region, I presume, right?
No, it does.
It
It
does?
should be. No.
So if we need the bigger agency's gonna wanna know the price tag hits.
Well, that's just for orders, right? I mean,
Right.
to use the radio for your normal.
Right. Every single call.
No.
No, it's just, that's just when
it's
you
only-
Your
it's
radio
only
report
medical
can still be
control.
given on the radio, it's only for when you're calling for doc's
Oh, okay,
orders.
so it
Right.
is just for
So,
orders.
yeah, so you just reduce, like, you know, how many times does the person really call for orders, who's the cost?
Especially with the new protocols, paramedics really don't call for much, so it kind of catches a good population for QI too, because it's either the upper level patients that you need to talk to a physician for something, or it's maybe the provider in the field is a little bit lost and wants a consult, so.
In the absence of Dr. Antonovsky, I'd say that the phone calls for Toradol would be the ones that are gonna pay the price.
You can call from the house before you leave.
Yeah, but what about when you have no cell coverage?
I don't think we have to.
Be like no difference.
That doesn't
Well,
email the health
oh well.
officers and cellular.
Pain management is what gets me. Just let me give pain management until they relieve or they dump the pressures. It'll give them more fluid.
So what about the scenario where no cell phone coverage? Does it ever work that you can do regular, microwave radio communication without cell phone?
Not recorded over.
No, I know that, but we could still get orders over
Sure.
the old system.
Yeah, absolutely.
It's not taking away from the old system, it's just adding another.
Okay, so I heard one comment about hospitals wanting to review.
Well, they'll wanna review what the plan's gonna be.
We
because
don't
now-
have a really proposal in front of us. Does somebody want to come up with a proposal?
That would go last
I mean, we can't.
Now it's time to throw Deb under the bus.
This is not ready for the C-suite, I can tell you. Well, we're gonna turn on some cell phones, is that all right? Like, I don't think it's something that I have to sink your teeth into, so we need to know. So we should probably, this is one example where we should definitely plagiarize from REMAC.
We're still in Remo's system, correct?
I am, well,
I'd be tagging
I don't
taking us over.
I don't think it's necessarily, there's no patient identification that's coming, it's coming.
No, but I
Well,
mean,
completely
this-
understand.
Yeah, you have to answer the hospitals, right? So Remo must have a policy around this, I would assume. Or a letter that went to their CEOs or came back from their CEOs saying, go forth, Dr. Daly. You don't know. So can we find that out?
Maybe the hospitals don't know they're being recorded.
Could we, Deb, could we get some kind of a proposal in writing, and then we can pass that around to all the agencies and get a little.
It's not ready for hospitals to review.
One thing that I would
It's a single participation. Your
suggest
agency could
is
start
if
recording
they
them right now.
possibly exist in the REMAC notes. About 6 months ago, Dean came and did talk about this particular issue, and I don't know what your notes may reflect on that.
It never went very far beyond just a rather cursory discussion.
I can certainly, obtain and get to whatever it is you're looking for, but.
Some kind of written proposal with some details in it, and we can email that around to all the agencies and get some feedback on it. That's just a thought, but I think that could be done fairly quickly, because the larger agencies are very responsive by email.
Oh, really?
I think somehow we need to make sure that every hospital is on board with this.
And so.
They ultimately have the right to say no.
What should the hospital do?
Well, I'm just saying that there's a legal aspect of this that has to be reviewed, because if something went wrong in a case, and this is gonna be pulled into court, and then the physician who the hospital contracted with to provide care gave orders, legal's gonna wanna just see what this care looks like.
According to my ex-law enforcement over here, what precludes me, what stops me from calling the hospital now and reporting it myself?
Nothing.
Nothing that I know of.
I think it's nice if you want to let the hospitals know, but I don't think that there's a legal
I
must.
mean, we've considered having everybody from medical control call in through our dispatch
Right.
and having it patched through, because our system is 100% recorded, and that way we would get away from the he said type situations.
I would love to see the system put in place, to be honest, I have no objection to it, but I just think that they would be.
If you ask
at least see what the
a
plan is.
hospital before implementing it and they say no, what are you going to do?
It's not gonna fly. Go ahead.
One thing with Remo, their physicians are credentialed. They have to take a protocol exam by Remo. A lot of our physicians don't. Some of them are not, they're just kind of by the book.
look into.
Well, we have looked into it in the past. It's a little bit like herding cats, to be perfectly honest with you. I'm a cat lover.
Herding cats that are on fire. Yeah.
But then that way they know what our protocols are, and you don't have this issue that you're referring to, because they
No, I
know.
think it's a perennial issue in our region, because I think Albany Med and maybe those hospitals are less dependent on locums staffing. So you have a physician who flies in for nights, he's gonna be on the radio.
I know, like the smaller hospitals, like Hudson and whatnot, they have, rotating stock of docs as well.
That's a separate discussion, actually. We're talking about recording conversations, whether or not they can force it. I think hospitals, I think the caution about hospitals, hospitals are gonna wanna know, that's a part of the medical record. Who owns it, where is it? Show me mine, show me mine. So there might be discussion about parsing it into hospitals, that hospitals get their own data, and the data doesn't live away from the hospital. So it is, I think, a technical, glitchy issue. We're saying that the advantage is as part of the medical record, really, where does it live? I think it's a great idea, if we could appease, there's a lot of stakeholders, right?
So are we gonna get what Remo has in place to be able to share the hospitals in the region?
He said, she said, with physician, there's a retirement goes every day.
All right, any other business for the REMAC?
Lunch.
Hearing that, we are adjourned, unless somebody wants to, wait, we're not adjourned.
We're not adjourned.
Okay.
I'm sorry. I was asked to come and follow up on a program director's phone call about a week and a half ago involving Coverdell in conjunction with the Department of Health and their oversight of stroke data. I have some paperwork here if anybody wants it, but let me preface that in talking with Phil at the beginning of the meeting, this presentation would only apply to agencies who are still currently using paper PCRs and are interested in upgrading to electronic PCRs. The presentation is there is seed money available.
Money?
Yes, money.
Listen up.
Okay. There is money available for those paper PCR agencies who wish to upgrade. The gist is through Image Trend. Okay, so that's the second part that you need to be aware of. And that seed money would be available only for the first year to help paper PCR agencies develop their electronic platform, i.e. Image Trend, and obtain the hardware that would be necessary for them to utilize electronic PCRs, i.e. Image Trend. And after that first year, those agencies would need to know how they would financially support that. right? The,
So the money comes from,
the money comes from Coverdale in conjunction with the Department of Health.
so it's not
But-
from the trend.
Well, it's tied to Image Trend, it's tied to Image Trend.
DOH is signing off. Good.
One other thing real quick. Last week, Tom and Mickey managed to get our entire office in a tizzy. I don't blame them. As of late yesterday, there is a new ketamine policy statement 1703, which now makes the protocols in line with the policy statement. Because previously, the daily deliverables that included that ketamine was on standing order. It now can be given on standing order. That line was taken out of the policy statement.
Detour.
Yeah,
Go back.
Hold on.
All right, so there's money available to get booted up with image
Basically, I was asked to come and say that this money was going to be awarded to only 2 regions. However, at the end of that phone call, there was some discussion that regions could actually, via a memorandum of understanding, join together. And that's where this comes in. Tim has talked to Travis up north. Evidently, Travis had some reservations, now would be agreeable. And would AAREMS be agreeable in joining into a tri-region approach to this? The data that would be collected, now this is from Image Trend, on stroke would be uplifted first to a regional bridge, but in this case it would be a tri-regional bridge. So not only could AAREMS look at its own data, but it could look at the data that had been sent from the Remo region and from the Mountain Lakes region. So it would give a bigger pot of data to examine for your QI. And that's pretty much it, I guess. After having listened to so much of the other stuff today, I guess mine's pretty easy. If there is an agency in the area that's still using paper that would want to upgrade to ePCRs, i.e. Image Trend electronic PCRs, and would be willing to accept the money for 1 year, but then could follow it up, because remember, once you upgrade to electronic data, you can't go back to paper. So this would be an irrevocable decision.
Any idea how much money would it totally offset the cost of startup?
It's $3,000 for the hardware, et cetera, and they're saying that would...
per agency?
Pardon? I can't speak to that.
All right,
but-
so it's money that's being offered very regionally. I think we should always say yes for money.
You have to find agencies, however, that could continue on in the second year.
Any non-EPCR agencies that want to speak here now?
Deb, in a given region that ties into this regional bridge idea, do all the agencies, all the paper agencies have to go along with this?
No.
They don't?
No.
Because
So
I'll
if
be
you
honest
had,
with
if
you.
you had agency A that said, you know, we're using paper, we were interested in upgrading, hey, if money's available, I'm gonna take it because there was already interest. But agency B said, you know, sounds nice, but we can't afford it in year 2. No, agency B would not have to sign on.
The only feedback I've gotten so far from our paper PCR agencies in AAREMS is that nobody's interested.
Okay.
Now, I'll be more than happy to query them again, but as it is right now, on Mary Gocke's proposal that I looked at, I was going to make a presentation on this afternoon during the AAREMS workshop meeting. Mary Gocke's proposal stated that they would, Martha Gocke, I'm sorry, I was looking at you, Mary, when I said
This is a confusing meeting.
It is, well, stay with us, you haven't seen anything yet. Anyway, her proposal was that the agencies would be given preference who are not using much in the way of electronic PCRs right now. Right now, in fact, 83% of our PCRs are generated electronically in AAREMS. I made that point to Martha and to Travis also in response to their inquiries. But in any event, I'll be more than happy to ask around.
Just for the record, the other 2 regions are on board with this, and they're happy to have us join them in the tri-regional stroke.
That is the message I bring.
Okay, so, all those in favor of AAREMS participating in a tri-regional application that would subsidize non-EPCR agencies to become EPCR? All those in favor? Any opposed? Good.
I do have one other thing. I asked Phil about the medication formulary on the new protocols. It was set up for each region to develop quantities on the medication formulary. Has there been any thought on that since
That's
this is
not
supposed
my,
to be?
my salary grade. So, who decides quantities that go in the back of an ambulance in a region?
The REMAC.
The REMAC.
It's in your salary.
All right, so you want.
Well, that fell right back in.
So, all those in favor?
Of making it not their responsibility.
So you have a proposal that we adopt? I mean, the more congruence we can have, I mean, if it makes sense to adopt, other regions.
Most of them, I would think that it would just go with what had been. It would just be the new medication that we would need clarification on of how much of what.
The new medication.
Here is the PREMAC, the medication formulary.
Like Decadron.
Yeah.
There is no recommended.
Also gets to stuff like, how much Lasix do you want to carry? Right.
How much what?
Okay, so let's
Lasix.
It's
Right.
gonna depend geographically. If you remember, God, how many times Connie Cato came here complaining about Cooperstown that they didn't need to carry as much as CMT because they're 10 minutes from the hospital versus an hour from the hospital. So it's basically agency dependent. What you need to develop is minimum par levels.
Right.
So what is the bare minimum that you want any one agency to carry? So you've got to go through and look at the protocols.
And if we're supposed to have this rolled out by the end of the month.
Right, so do we know from our electronic database, Phil, how many drugs each agency is using, so we can have some science behind
How
what
much
the
they're
level
using, I
should
can
be?
take a look and see how far we can get into that.
All right, so we should do a side-by-side. We can look back at 2016.
Right.
Take out, CMT, GAVAC, some high volume agencies, divided by the number of runs, you can figure out their runs per month, you can figure out drugs per month by agency. We have all the data. We shouldn't be shooting in the dark about how many you think you're getting.
You got to take in consideration long transport times too, though.
Yeah. It's not necessarily how much you use per month, how much you use for a single call. How long you've been on the road. I mean, you can always get more when you go back to the station.
You just don't want to run out of certain things on the
We
way.
have last year's supply levels, so we just approve that for now and then go back. We have last year's supply levels.
So the only thing that would be the Decadron.
Sorry, we only have one load fed.
What's the question about Decadron? It's a new drug.
It's a new drug. So how much?
Well, it's a new drug now, it didn't used to be. We used to
Well,
have it.
right, but I mean, as far as comparison to last year's
Yeah.
formulary.
Pain management, basketball, and leather strings. Play hard, sir.
Because you also need the PO and the IV as well.
So what did we used to have? Solumedrol. How many of those did we used to go for?
We used to carry two.
Two. All right, two. All those in favor? 20 milligrams.
20
I
milligrams
think
on the
you said, I think
diagram.
this is gonna be something better, best distributed electronically, because to ask people to call out this stuff
That was in
is a crapshoot.
Okay.
Well, not only that, but also the agencies.
7-10 split.
Well, two work for you guys, right? Two of 10.
On the 30-yard line,
Now, is
the
that-
runners
is
have
that-
Oh,
7.
does it
PO
say,
as
so
well.
they're saying 20.
There is no,
You shoot it
give
from half
them
court.
the IV injectable PO.
All right,
So you do give
if we
the
adopted last year's supply
PO
levels,
on that.
and we added Decadron, 20 milligrams total, 2 times 10 as a supply par, minimum par level. Are we good? Okay, all those in favor?
Yeah.
All right, and Dr. Fisher wants to weigh in. One last comment. Go ahead.
Requirements for EMS to be leaving charts at the hospitals. We're having a horrific time.
It's the other side of the EPCR
Yeah.
thorny issue.
So the hospitals want information on patients left before the ambulances leave. And that there's a great, there's a great hole in our hospital and probably most of the other hospitals in our region, and it needs to be addressed.
I think it's a good, so if I recall this conversation, yes, it's an issue. Yes, it continues to be an issue. Even the electronic PCRs that are completed like sometime tomorrow don't make it into the Sparks data as they should. So there's many hospitals required by DOH to include PCRs as part of their Sparks data, minimum data set, that are lacking PCRs in there because, well, it was never great to begin with, but ePCR actually didn't enhance the result. And one of the things we had last discussion was a paper form to be left at all times, universally adopted across the region. And we got pretty close to that. I'm trying to remember if we ever put the nail in the coffin. Well, we had a form.
You had like 3 forms you were looking at.
Right, that's
And that's as far as it went.
That's as far, what you decided was that a form needed to be used, and the agencies could determine what form.
So is it, do we have time today to check one and go with it forward, promulgate it across the network?
I can tell you, I've already printed several thousand of a form, and I know you have several thousand of your form,
You guys
and,
using the same form?
no, our forms are different, but they're forms that are being utilized.
So you have 2 forms, equal in content. So we just do eeny, meeny, miny, mo.
20 and 5, 10 and 1.
Yeah, a lot of agencies are already doing it.
No, we don't want lots of different forms. We want standard, singular, regional forms.
It depends on the hospital.
Let me just create one content table. So we have GAVAC, and we have
No, that's what they
CMP.
just-
Does anybody else want to put theirs in the final list?
But it's not, this is what they're
Can
saying.
we bring the forms and address this in the next meeting?
Why don't you just establish minimum requirements of information
wants
for
the
the
same
board?
form
He
for
wants
everybody.
the same form for everybody.
Yeah, but
And it
still
just
read those off the
depends on the
website, so
hospital.
maybe
I don't
during
know what
lunch.
tour's gonna give us. We don't-
I don't think it matters. I mean, the content is, highly dictated by others.
I have several forms in my computer.
And you
I
can
just
do
need to
the
pick
eye
one
thing
and run with
around.
it.
You can get the eye
I'll
thing.
pick one and send it around the agency.
Okay, just pick one.
I'll just pick one.
Not
Okay.
eight. Okay, so that'll, and then we're gonna require that be let, that particular form be left. Well, ePCR is being, formulated. All right? It is an issue. I mean, there are lots of instances where
The legal choice of-
hospitals look into their medical record and say, show me the PCR. There ain't none.
It's not a PCR, it's more of a.
It's a handoff.
This would be the surrogate for the PCR.
It's a
The other
handoff.
problem we see is we give them to the RN taking a report and they discard them in the circular file.
There's a lot of that. There's a lot of
Ours will
EKGs
not be
that get discarded, I think.
They won't.
All right.
You're much better.
You guys still gonna circulate a form. We should put a title and a head on it, Phil, so that hospitals in the region will hopefully scan it in the way they would the PCR. They can always scan the PCR in addition, but it's a pre-hospital form. Yes.
Thank you. I'm a guest here, and my name is Maggie Hunt, and I'm the new manager at Nathan Latour. It's been a long time, Dr. Reinhardt. From what I can see from those forms that you're sending me, they're being thrown out. There's nothing on it. I get a little scribble of information that tells me nothing about what happened on route that doesn't close the loop. And in my opinion, you're asking double documentation. So, what you put on here, and then make sure it's, now you've got
Maggie, I would
documentation
say-
that you left at the hospital, and then you finally finish your PCR and there's a discrepancy.
I would say check the agencies that are doing this and give me their names, because not every agency is doing this. I can attest to that.
Would it make more sense to put a
I
limit?
just, from what I've seen in the last month, the papers, I don't get them routinely, and what I do get is,
Some
I
agencies
get
are.
occasional that's complete and they photocopy these, or I get it all thrown in the box, I have no names on them.
We have a QI process to take care of that, just such a
Fill
problem.
the
You tell me the
enforcement
names of
process.
those agencies, and I will deal with it, I promise you.
We could require verbal report.
Just to let you know, I'm over 100 PCRs behind in EPCRs to get anything information. Not that piece of paper that you're dropping off, but completed PCRs. I'm over 100 PCRs behind in collecting that data. And I'm on the hunt. I have 3 full-time work clerks now searching for it. I have an entire
Oh no, I'm gonna make it worse.
medical records that are keeping track and reviewing and looking for it. We've got a whole process now in place just to keep hounding you guys to give us the information that should have been given to us before
You give me the name of the agencies, and I will personally put the hammer down.
Dr. Leinhardt just brought it up, so I'm just gonna push him in front of the bus that I'm driving. But he said, wouldn't a verbal report be nice? I know by the state we're mandated to leave a copy of the PCR at some point in time. There's an extension of that, perhaps a verbal report with a signature of an accepting a patient, and receiving a verbal report would not only prove better that we get provider turnover and eliminate what Maggie just brought up, which is, welcome to your first meeting, by the way.
And possibly your last.
They're usually much more fun. Bring popcorn. And eliminate the double documentation.
I can tell you that we get a verbal report now. We even developed a pre-hospital screen for the nurse to document her verbal report on.
So
And we require an RN to sign
we.
every one of our